So the question is, when you do a pulmonary angiogram, how do you decide whether catheter-directed thrombolysis versus large bore or small bore embolectomy? So it's important, as we pointed out, that the large bore embolectomy is a 20 French and now going on to about 16 French venous access. That's number one. So you need to decide what's the patient BMI. Second, the large bore or embolectomy will take median time of about 2 hours, whereas your local thrombolysis median time is about 25 minutes in an experienced lab. Third, if the RV is severely dilated, the large bore embolectomy catheters may not be the easiest to navigate through the dilated RV. If the patient has moderate to severe TR or severe pulmonary hypertension, you may cause some kind of hemodynamic compromise during those cases. So these are considerations to keep into large bore embolectomy. In general, any patient who does not have any major contraindication to thrombolytics and if the patient is stable, would be a good candidate for local low-dose thrombolytics. So based on optimized data, you could do a 6 hours infusion, 1 milligram an hour, both sides, each side, and even if there's a large proximal clot, both sides, you would get a good result. It's extremely important to make sure your patient's blood pressure is stable, because all these procedures will take their own time between 4 and 6 hours for the patient's hemodynamics to improve.
And
Yes.
Go ahead. Well, I think it's really important to recognize that there are a lot of ways to skin all these cats, and we have not figured out which is best yet. And everybody has different opinions. There's some data, but there's not a lot of data. But after doing this for 20 years, I think I've used almost every device that's out there, and I've gone back to low-dose lytics. Tenecteplase has a very high fibrin binding specificity. You can run it at 1/4 milligram an hour and have amazing results. The patients are hemodynamically stable. If you start using mechanical thrombectomy devices in stable patients with submassive PE, you will turn some of them into unstable patients. So I use mechanical thrombectomy devices. In fact, the Teratol is the fastest and easiest one to get in over a wire and open the pulmonary artery up. When people are crashing and they can't be transferred and they're going to die, and we don't have a cardiothoracic surgeon to crack their chest in our institution. That's the only time I use it now. And we do a lot of these, because being at altitude here in Denver, we have tons of PE. I mean, I've taken a patient with a platelet count of 30,000, given them platelets, creatinine of 3, parked a catheter in, and run it at a 0.125 milligrams an hour. She goes from being almost about to crash to totally stable within 6 hours on 2 liters. You pull everything out and they do fine. So we need to tweak our protocols, but I think low-dose TPA is going to be the answer in the majority of these patients over time.
Yes, and to your point, I think whenever you do a pulmonary angiogram, it's very important to look at a CT angiogram before you do that. To the point being made that TPA is effective in almost all the patients, because almost all acute PE is not all acute PE ever. There's always a subacute or chronic component of the clot. So if you give thrombolysis, there's a high chance of recanalization and not just declotting. So the concept is not declotting only, is recanalization. So whether you recanalize by ultrasound-assisted thrombolysis or a non-ultrasound-assisted thrombolysis catheter, I think it is a flavor of the day usually that you decide. And of course, most of the patients that we enrolled in the large bore embolectomy were in the FLAIR study, so we had access to all the data. But it is the most convenient or the comfortable you feel. I don't think you should be master of all devices, but at least one or two. One embolectomy and one thrombolysis, that should be a go-to device.
Yeah. I want to echo that point. So right off the bat, there's going to be people who have absolute contraindications for thrombolysis, or at least quasi-absolute contraindications for thrombolysis. So you have to be comfortable with not only thrombolysis, but with some sort of mechanical thrombectomy device. I want to also state that hemodynamically unstable patients, the answer is not catheter-directed thrombolysis. That's for sure. It takes too long to work. Mm-hmm. In fact, I would tell you that people who die from PE die from hemodynamic collapse from right heart failure. So in our institution, the treatment for those patients is hemodynamic support. And then once you have them on hemodynamic support, unfortunately, lytics doesn't often go well with those patients, so we end up doing mechanical thrombectomy. But we watch patients' PA pressures go from 90 to 35 on the table with mechanical thrombectomy. But again, if they're unstable, the answer is hemodynamic support. And then you're going to have to treat them, which for us is mechanical thrombectomy, because lysis just doesn't work well with ECMO.
The other thing I'll say I learned in my experience, which I would like to hear you guys, is anesthesia support. In most of the submassives, I've learned not having anesthesia is better. I think the least amount of sedation you give in these cases are actually better for you. I've had patients that as soon as they give the deeper sedation, I've seen them tank because the reserve goes down. So I try to use all these under just local and very mild sedation.
Yeah, in the spirit of civil discourse, I would like to disagree with a lot of things. And that is, we've done a lot of trials on this, and I acknowledge that there is a role for catheter-based intervention, but it is very minimal. Mm-hmm. It is very, very minimal. And I don't believe you should put a catheter inside the pulmonary artery. Why? Because God's catheter, which is the vein, takes all that TPA to the lungs. So you don't need to put a plastic catheter there. And anything you give, all those molecules, if it is through the capillary or a central vein, winds up, converges in the lungs because it takes 100% of the cardiac output. We can debate this for a long period of time, but I think low-dose systemic thrombolysis from a financial and a health perspective policy is the way to go for moderate for submassive and massive PE.
I want to say that I agree with the last comment, really. We reverse back to IV thrombolysis now away from catheterlysis. Not in exist anymore.
Someone died.
Yeah, for open, it's for chronic pulmonary hypertension, for endarterectomy.
No,
Yeah, if
that,
someone's dying, you can put them on ECMO. And
Yeah.
well, I think too, if you've got a strong contraindication to thrombolysis, I think there is a role for open thrombectomy. So in our institution, we don't do many, but certainly, if you've got somebody who's just had, a hip replacement, knee replacement, they have massive PE, they have to be able to be anticoagulated because they're going to get systemic anticoagulation for cardiopulmonary bypass. But I think there is a role for patients for open thrombectomy if you have appropriate experience, expertise, and availability. But that's the point, right? You have to be able to mobilize that patient immediately to the operating room. Because you're not going to take a stable patient there, even quasi-stable, but there is a role. There's no doubt.
And you have to have ECMO on standby all the time for those cases. We did about 3-4 cases with the cardiac surgeons, and all of them had surgery before, so we could not lyse them. So that's the role, really.
We ECMO.
Can
we're
you
talking about
repeat the question? Sorry, repeat the question, please.
Crashing mass. He said, "What hemodynamic support do we prefer?" I'm talking about the crashing massive PE that shows up in our emergency room. We're going to put them on ECMO, and that's going to save their life. And I also agree with the point made. It's plenty. Very often I'll get a call from the floor and someone's crashing and they want to tube them, and I say, "Please do not intubate the patient until we get them on support, because as soon as you undergo rapid sequence intubation, they die." And then you're doing CPR. And so I agree with these points. In fact, I have partners that don't put any catheters in lungs at all. They just give TNK through an IV. But again, there are people who cannot have lytics. You have to have a plan for those patients.